The transplant field is moving very rapidly, and when we consider auto-transplant for multiple myeloma, this era is really becoming more and more exciting. Over the last few years, we thought that maybe the transplant activity will decrease or even disappear because of the advent of new drugs. But actually, when we look carefully, the transplant activity is growing worldwide, and actually transplant results are clearly improving. So when we look over the last few months or couple of years, we've seen some major advances when it comes to induction prior to transplant. For many years, I think the mainstay for induction was the triplet combination, bortezomib, IMiD, lenalidomide, thalidomide, and dexamethasone. Alternatively, you would use cyclophosphamide, an alkylating agent, VCD. So for many years, we lived with VTD, VCD, VRD, which is likely the most popular one. Now we know very well that quadruplet combinations are going to become probably the standard of care, thanks to the daratumumab VTD combination validated through the Cassiope trial, but also daratumumab VRD, which was published recently through the Griffin trial. Another exciting aspect when it comes to induction is about this endurance trial, randomized phase 3 trial, comparing the classical VRD versus KRD, carfilzomib, lenalidomide, dexamethasone, versus bortezomib, lenalidomide, dexamethasone. And the common belief for many years was that if you replace first-generation proteasome inhibitor by a second-generation proteasome inhibitor, you will improve your results. And the biggest disappointment in this field came from this so-called endurance trial, showing no difference between KRD and VRD for induction. Obviously, there are several explanations to this. I'll not go into the details. Nevertheless, it looks like that having a quadruplet introducing an antibody with a new mechanism of action is actually more beneficial than just, playing or modifying the composition of a triplet combination for induction. When it comes to conditioning regimen, I think melphalan 200 is here to stay. It's unlikely that to see a huge change in the near future, but I believe that the consolidation, but also the maintenance field or component of the transplant procedure is going to change progressively. Lenalidomide is a standard of care for maintenance, but more and more we see the advent of oral proteasome inhibitors like ixazomib, maybe in combination with lenalidomide, but also daratumumab as an antibody in combination with lenalidomide, and trials are already running. So at the end of the day, the transplant, auto-transplant for multiple myeloma is really moving nicely and in the right direction, because all the novel drugs are now being combined with the high-dose chemotherapy, and this is definitely improving the outcome of the patients.